Okay, so let's talk about this topic, which is Scfe, right? So what exactly this means? Scfe. Scfe simply means it is slipped capital femoral epiphysis. This is slipped capital femoral epiphysis. Now what does that mean? What this definition, or the you can say full form of this word Scfe tells you? It simply means that something is slipping. What is slipping? There is a slip of the capital, femoral and epiphysis. Now what is this slip of the capital, femoral, epiphysis? See, understand this. This area, this is the epiphyseal area, correct? And that is a metaphyseal area. So slip of the capital femoral epiphysis, the epiphysis which is on the capital side, the head side of the femur, it has slipped. Now where it has slipped, why it has slipped, that is a point, right? So this is the full form of this topic that we are going to discuss today, that is Scfe. Now you should understand one very important point. Now the full form of the topic says that epiphysis has slipped. The epiphysis which is on the upper side of the femur, it has slipped. But has it really slipped? We just need to look onto that. Just see, this is the epiphysis and this is the acetabular margin, correct? And this is the acetabulum margin and this is the epiphysis. That means on right side as well as on the left side, on both the sides, the epiphysis is still in the socket. It has not slipped anywhere, isn't it? It is still inside the socket. What has actually slipped, you need to just focus here. This metaphyseal area, it is in connect with the epiphyseal area, but here the metaphyseal area, it is not in connect. Instead it has slipped, it has gone above the normal area, normal margin, right? This is the area where the metaphyseal area of right side is, and this is the area where the metaphyseal area of left side is. That means the epiphysis does not slip. It is wrong to say that in Scfe the epiphysis slipped. There is the most important point, there is no slip of epiphysis. There is no slip of epiphysis. I hope this point is clear. Then what is happening, we'll get into details of that. So there is no slip of epiphysis, therefore this terminology Scfe is absolutely wrong. It is not correct. There is no slip of the capital femoral epiphysis. Okay, so this is a misnomer. It's a wrong term to say that the head is slipping, the epiphysis is slipping. Okay, now why this happens and what is slipping, we'll just look on to that. Now why this happens, what has happened? See, you all know that this epiphyseal area and there is a metaphyseal area, and in between that, what is this area? This is what you call growth plate, right? That's what you call the growth plate. Now what happens, because of certain factors, there is weakness of the growth plate. What are all those factors, we'll just discuss about that. But because of certain factors, there is a weakness of the growth plate, and because of weakness of growth plate, these epiphysis and metaphysis, they don't remain stick to each other and they go away from each other. What are those factors? The factors which are responsible, we can say the etiology. If I talk to you about etiology, what are the etiological factors for Scfe? There are three main important factors which have been contributed in different books. One is what you call the mechanical factors. One is what we call the mechanical factors. Okay. Second one is what we call the endocrinal factors. Endocrinal factors. And third are the genetic factors, which cannot be absolutely changed. So genetic factors. These are three main factors which contribute to the development of Scfe. How it happens, what it happens, we'll just see. So there is no slip of epiphysis. That is the most important thing you have to remember. Please don't forget this. In your exams also, they ask you that what is the direction of slip in epiphysis in Scfe. So do remember, there is no slip of epiphysis in Scfe. That is the most important point. Okay. Now what are the these different mechanical factors? The different mechanical factors which contribute, the most important ones I'll tell you, is the perichondrial ring complex becomes thin. The ring complex which is all around the head area, it is thin, the growth plate basically. So thinning of perichondrial ring complex, thinning of the perichondrial ring complex. That is point number one. Second, mechanical factors. Mechanical means which denotes or which represents the problem with the basic anatomy of the bone, right? Second is the retroversion of the femoral neck. Now what is that retroversion? What is the meaning of retroversion and anteversion? Retroversion of femoral neck. Now understand this. If this is a femur, I hope all of you can recognize it. If this is a femur, when you see that in AP view, that should be your AP view, you see that the neck, this is a shaft area and that is a neck area, and this is what you call the neck shaft angle. Okay, if the neck shaft angle increases, we call it a valgus deformity. If it decreases, we call it a varus deformity, coxa vara and coxa valga. Now what is this retroversion and anteversion? When you see the femur, this femur from the lateral side like this, when you see it from like a lateral side like this, you will be able to appreciate that this head is not in straight line with this shaft, right? It is not like this and this, it is not like this, it is slightly anteverted. That means it is slightly towards anterior line. If I draw a line from here, that will be, head will be going here. Basically we measure it from the condylar area. We draw a line here and then we see how much, we draw a line here on the condyles and then we see how much anterior is the neck of the femur. That is what you call anteversion. Normally it is 15 to 20 degrees of anteversion which is present in an adult. In children's, the anteversion would be around 28 to 30 degrees, slightly more as compared to the adults. In males, the anteversion is slightly less as compared to females. So all in all, a normal anteversion is that this shaft or the condylar area, the straight line here, perpendicular here, should be, when you measure the angle with the perpendicular line, the head, the neck basically, not the head, the neck should be 15 to 20 degrees anterior like this. So this is a normal femur, how it is placed in your hip area. So around 20 degrees of femoral anteversion. When this anteversion is less, it has been seen to promote the formation of Scfe. In which children? We'll just talk about that also. Okay, and then coming on to the endocrinal factors. So endocrinal factors are related to the disorders definitely. What are the different disorders that the child may be having? Number one, imbalance in the thyroid hormones, association with thyroid hormone, or it has been seen in association with the sex hormones also. Thyroid hormone or the sex hormones, number one. Number two, it can be associated or seen in conditions where associated with chronic renal failures. Chronic renal failure. Number three, it has been seen in association with different syndromes like Klinefelter, like Turner, etc. So Klinefelter syndrome, Turner syndrome, etc. So syndromic relationship basically. Okay, genetic factors, as I said, they cannot be manipulated, they cannot be changed. So you know what happens here in Scfe, the head is in its own position, it is not slipped, it is still inside the socket. You can easily understand it. If it moves out of the socket, it is known as dislocation. That is not Scfe then. Okay, so first we learned the most important point, that the definition itself is a misnomer, it is wrong, the full form is wrong. Okay, the question number one for our PGME, the epiphysis does not slip, right? Rest of the bone slips, the neck basically slips, right? Okay, so this is the etiology. Now the point is, it is seen in whom? More it is seen, the incidence, it is slightly more in males as compared to the females. Slightly more in male as compared to the female. Okay, now what happened? The features here, in the features here, what happens? The neck, basically, the neck displaces, neck means the metaphyseal area basically. So the neck displaces anteriorly, displaces upwards and anteriorly, the neck displaces upwards and anteriorly as compared to the epiphysis, as compared to epiphysis. Now if in your exam they ask you the question that what is the direction of slip of epiphysis, so you have to simply say there is no slip of epiphysis. But if they ask you what is the position of epiphysis in Scfe, then according to this particular line that we have written, what should be the position of epiphysis? The neck, the rest of the bone is moving where? Anteriorly and upwards, right? So where the epiphysis will go? So the epiphysis, is displaced. So the epiphysis is displaced where? If the neck is going anteriorly, this, If the neck area is going anteriorly as compared to it, the head is going on which direction then? The posteriorly. So the epiphysis is not displaced actually. The epiphysis is placed posteriorly and medially. It is placed posteriorly and medially. So what is the position of epiphysis in Scfe? It is posteromedial. So do remember, the position of epiphysis is posteromedial. Does it slip? No, it doesn't slip. Okay, but point is, why this happened? Epiphysis is in its position, metaphysis slipped, but why? It is all because of the weakness of the growth plate. Where does this happen? Where does this happen? The slip, where does it happen? So it is seen in point number 2. It is seen with weakness of the growth plate. It is seen, or it occurs, you can say, due to weakness of growth plate. Which zone? Due to the weakness of growth plate. Weakness of the growth plate. Right? So as I said, growth plate, if you remember from your basic anatomy, you know that growth plate has got 5 basic zones. Okay, so this one occurs at the hypertrophic zone. This one occurs at the zone of hypertrophy, the hypertrophic zone. Okay, this one occurs at the zone of hypertrophy. Fine. So this is where the weakness is, and because of this weakness, there is no contact between the epi and metaphysis, and the bone slips. Now it slips in which people? The mechanical factors, this endocrinal factors, and the genetic factors we have discussed. That means those children who are having either the hormonal imbalances, sex hormone, thyroid hormone, or those who have the anatomical problem like lack of antiversion, that is more of a retroversion, those people, those children have got more tendency. Okay, point number 3. This is more commonly found in the adolescent age group, right? It is more commonly found in the adolescent age group. So most common presentation when the child can come to you is somewhere between 13 years to 15 years. That is 10 to 15 is a common year, right? How the child will be coming to you? What will be the presentation like? So obese adolescent child, obese adolescent kid presenting with, because the anatomical position of the joint is not proper, the epiphysis and metaphysis are not together. So obese adolescent presenting with a painful limb, presenting with a painful limb, right? So adolescent obese presenting with a painful limb. So do remember, these are other 2 important features. Painful limb. So it is a painful limb when the child is having Scfe. You must remember the causes of painless limb and painful limb in a kid. So adolescent, obese, painful limb, usual cause can be Scfe, right? So normally this will be the commonest presentation. When you examine these patients, basically this presentation will depend on the type of the slip. This slip, Scfe, this can be of 3 types. This can be broadly of 3 types, right? What are those? One is an acute slip. We simply call it acute Scfe. We call it acute Scfe. This is acute Scfe. Okay, that is acute Scfe, acute slipped capital femoral epiphysis. Basically, the presentation of the acute Scfe, it is similar to a trauma, like a fracture. Okay, so there will be the prodromal symptoms if they are less than 3 weeks. When the prodromal symptoms are less than 3 weeks, we call it acute Scfe. Okay, so these present with a sudden fracture-like presentation, like a fracture has occurred somewhere. Then there is something known as chronic Scfe. What is chronic Scfe? Chronic Scfe means when the prodromal symptoms have been more than 3 weeks, right? So it is a long duration. Basically it is a long duration with how the patient will be presenting to you. Patient simply tells you that I'm having some sort of vague pain around my groin area. So long duration vague pain around the groin, vague pain around groin, okay, around the groin area. So when you start examining, you'll find certain features that we'll just talk about. And third one is known as acute on chronic Scfe. Third one is acute on chronic Scfe. So acute on chronic Scfe. What does that mean? It was a long-standing, more than 3 weeks duration case where the presentation has suddenly increased. The symptoms have suddenly increased. Okay, sudden exacerbation of the pain. That is what acute on chronic Scfe is. Okay. Now, when you examine these patients, one thing is for sure that you are going to find what? The findings. You are going to find what? The groin pain, that is tenderness around the groin area. So when you press in the groin area, there will be tenderness. So tenderness at groin, that is one thing you are going to find here, right? So adolescent child walking with a painful limb, when you press, there is tenderness at the groin, and there will be restriction. The important point, because of this slip, what is happening? There is restriction of internal rotation and abduction. There is restriction of internal rotation and abduction, right? So there would be painful limb, that is what you call antalgic limb. Second, the restriction of the internal rotation and abduction. So how the child is keeping the limb? It is slightly externally rotated, more of a external rotation. Okay, so there is one classical sign which is related to it. There is one classical sign which is related to Scfe. And what is that classical sign? The classical sign is known as obligatory external rotation. The classical sign is known as obligatory external rotation. What is the meaning of obligatory external rotation? When you flex the hip of the patient, on flexion, basic meaning of this obligatory external rotation is on flexion, hip goes in external rotation. So hip goes in external rotation. So please mark this. This is also very important for PGME, obligatory external rotation. Where else do you see obligatory external rotation? Obligatory external rotation, differential diagnosis for this. So differential diagnosis for obligatory external rotation, do you recall? One is this, we have just talked Scfe. It can be seen in Perthes. It can be seen in idiopathic avascular necrosis in adults. So these are three important differentials for obligatory external rotation. Another question for your PGME. On flexion of the hip, the patient is lying supine, and when you flex the hip of the patient, it automatically turns out. That is external rotation. It will go into external rotation. So restriction is of which movement? It is of internal rotation and abduction, right? It is of internal rotation and abduction. Okay. So when you investigate, next point, these are the findings, important findings that you should always remember. When you investigate, the first investigation that we always get done in orthopedics, it is X-rays, isn't it? That is X-rays. So what important you are going to find on X-ray? X-ray may not be classical all the time, like I have just shown you, right? X-ray may not be classical every time like this one. They may not be so classical like this one. So what you have to do in X-ray, you have to draw one line. You have to draw one line, and from where to draw that line? You have to draw a line parallel to the superior femoral neck like this. You have to draw a line parallel to the superior femoral neck like this. This line is what you call the Klein's line, K-L-E-I-N. This is what you call Klein's line. When you draw this line, the part of the femoral head is always intersected. That is a normal finding. Okay. When we do same on the opposite side, see what happens. If I draw a line parallel to the superior femoral neck, this is how it goes, and the head is not getting intersected. So when the head doesn't get intersected, that's what you call Trithoven's sign, right? That's what you call Trithoven's sign. So one is Klein's line and other is Trithoven's sign. So Trithoven's sign is our abnormal finding when the line is not intersecting the femoral neck. So Klein's line is a normal finding. This is a normal line. intersecting the part of the femoral head that you can see. This part of the femoral head is getting intersected. So on X-rays, you are going to find that on plain radiograph you can find, or you can just draw, number one, the most important I told you, the Kleins line. So this Kleins line will help you out to find whether there is a dislocation or no. That's what you call Kleins line. Okay. Second, there are a few books where I have found the questions about CT scan. Which of the given investigation is not useful for Scfe? So do remember, X-ray can be helpful. You can draw the Kleins line. Second can be CT. So these are not useful to document or treat this Scfe. These are not that important. These are not that important to treat or document Scfe. You don't need a CT scan to document it because it is of not much of use. Yes, you can use CT scan for other purposes. For example, when you operate it, when you fix it, then you can just do the CT scan to see whether the screw is entering into the joint area or no. Then it will tell you the better demarcation. Okay, so it is not that useful. Also, you can be useful, that you can note down or you can remember, can be useful to see the anteversion or retroversion. Can be useful. I have told you what is anti and retroversion, to see the anteversion or retroversion. Anteversion or retroversion of the femoral neck. How much is the anti or how much is the retroversion? Okay. Point number 3 are the scans. Technetium 99 scans. Technetium 99 bone scan. Technetium 99 bone scan. Okay, so they can tell you if the basically what is the inference that comes out from the this scan, Technetium 99 scan, is that there will be increased uptake if there is initiation, or if there is involvement of epiphysis, right? And there will be decrease if avian has started settling in. If avian has started, then it will show decrease uptake, right? So when initially there is an inflammatory response, or it is increased uptake will be seen in the initial phases of Scfe. As soon the development of avian, because the epiphysis and the metaphysis, when they are away, definitely there is some sort of compromise on the vascularity, so that can lead to avascular necrosis. If avian will start at any point of time in Scfe, the uptake will be decreased. Number 4, after technetium scan, will be the role of ultrasound, will be the role of USG, right? So it has been used basically by many people for routine examination. It has been used, or it has been useful in the initial stages, has been useful to diagnose initial slip, where in addition to the slip, what more we can observe is a effusion. In the joint can be seen, right? That will be seen as a step or a space between the femoral neck and the epiphysis, which is created by slipping, right? So a step can be observed between the head and the neck area. Why it is created? Because of the slip, because they have moved away, right? And obviously the best for any case, you all know, the best investigation to be done for any case, any condition which can lead to avascular necrosis, always the MRI, right? So MRI is always the best. Where else MRI is best? Do you know? Can you recall? MRI is the investigation of choice at what all other areas? Differential diagnosis, where MRI is best. The differential diagnosis for MRI is best. Number one, fracture neck of femur, fracture scaphoid, fracture talus. Why? Because all three, they have a common complication, which is avian. Then the stress fractures. Then the stress fractures. Number 3, condition of Scfe that we are talking right now. Then Perthes, right? And included in the stress fractures are your March fracture. These are the differentials where MRI will be best, and all of these are your MCQs for PGME, right? The differentials where MRI is best. Now, what will be the treatment for these slips? If the slip has started somewhere, you have to stop it. If you don't stop it, what can happen is a complication, right? So what are the possible complications if you don't treat it, or if you treat it wrong? The complication will be, number 1, chondrolysis. That means loss of the cartilage, it may be damaged. Second can be avascular necrosis. So chondrolysis and avascular necrosis, these are two possible complications which are related to Scfe. How do you treat it then? The acute slip, you know that the acute slips will present how? Like a fracture immediately occurred, and it will be like a fracture. Okay, so treatment would be, initially it is conservative. But if required for surgical purpose, what we can do is percutaneous pinning of whatever has been slipped, right? Fixation by percutaneous pinning, right? So do remember, the complications related to this Scfe is avian, and that's why the MRI is the investigation of choice. So if I mark some PGME questions for you from this particular topic, number 1, number 2, and this I found in some of the guidebook, they asked the question which of these is least helpful in the diagnosis for Scfe. So you can mark very well CT scans. All the USG and all are also not done. Short is X-ray and then get a MRI, and nobody gets a USG and all those things. But yes, CT as per literature, CT is of least use. Then next, obligatory external rotation, restricted movements, then this limp, whether it is painful or painless limp, in which direction, what is the position of the epiphysis as compared to the head, then is epiphysis slip or not slip? So there is no slip of the epiphysis. And as per the X-ray, important point, Klein's line and the Trithovan sign, right? So this is in short about Scfe, slipped capital femoral epiphysis, where you can have many questions, or you can simply say that these can be asked as options for question of Scfe. Thank you so much.